Thank you so much for having me here today and inviting me to speak. My name is Shivani Kamat, and I'm excited to be here. So today we're going to talk about some laser and surgical solutions that we can offer both in the clinic and in the operating room. So we have discussed some of this already, but just to do a quick recap, glaucoma has a lot of risk factors, and the main one that we can control right now is eye pressure. And what we do is we try to lower the eye pressure, and that's the main modifiable risk factor that we have right now. And I like to think of it as the eye is like a sink. It's constantly making fluid and draining fluid, and this fluid is called aqueous humor, and everything we talk about revolves around this aqueous humor. Many of the problems originating or with glaucoma originate in this drain. And this is how we also distinguish between the types of glaucoma. So glaucoma can be split into two categories broadly. There's open-angle glaucoma and closed-angle glaucoma. In open-angle glaucoma, the drain is open. We have a technique that we do in the clinic where we can look at the drain, and we look at it and we can see all the structures. It's just malfunctioning on a cellular level and on a level that we can't really see in clinic, but we know it's not working properly because your eye pressure is elevated. In closed-angle glaucoma, the angle is actually either smaller in size than average or completely closed off. So if you think of a sink that gets clogged and the fluid is backing up in the sink, same concept of what's going on in the eye. And so there are various things that we can do both in clinic and in the operating room that can help these scenarios. And first I'll talk about some options in the clinic. So the first thing is a laser option that we do often in the clinic for treating open-angle glaucoma, and this is called selective laser trabeculoplasty, or SLT. So like Dr. Butler was talking about, taking eye drops is difficult for a variety of reasons, and we know even those with the best laid plans, really responsible, really motivated to help treat their glaucoma, don't take their drops consistently because either life gets in the way. I think that's a very common one. Just, we're busy, and some of these drops, especially if they're dosed in the middle of the day, we're often out, and so we're not near our drops. Drops can be expensive. They can be difficult to administer because, like she mentioned, some people have arthritis, they're tiny, it's hard to squeeze them. And many drops have side effects, red eyes, irritation, skin changes that are permanent. And so for all these reasons and more, we have found that many patients are just not as compliant as we would like with these drops. So SLT is a low-risk intervention that we can do in clinic that lowers the eye pressure and often can decrease the patient's drop load. In some cases, eliminates the drops, depending on how many drops you're on. When you go into clinic, you sit in something that is just like the slit lamp that you're used to sitting in when you get your eyes checked. You see lots and lots of lights. We use a lens that magnifies the area that we want to treat. That's probably the weirdest part of the whole thing, is you might feel a little pressure from that lens, but otherwise you should not feel any pain. If you do feel frank pain, let us know. We can adjust the settings of the laser and make it so that it's more comfortable for you. Like I mentioned, you'll see a lot of light. You will hear a lot of beeps, so sometimes up to 100. That's totally normal. That's a normal course of treatment. And the whole procedure really takes only a couple minutes, so it's pretty straightforward. Right afterwards, it's very common to be a little bit blurry for about 20 to 30 minutes, but most people don't have significant changes or symptoms post-laser. You may be prescribed an anti-inflammatory drop after the laser. If you do have any symptoms like redness, blurry vision, just discomfort, this drop does a really good job of treating that. But many of my patients often don't even need to take a drop after the laser. There are no restrictions after the procedure. You just go back to normal. And it's a very low risk but high reward, potentially high reward procedure that many of us, if you ask even many of us physicians, we would want it in our own eye or for those of our families or loved ones. Now, a laser option for narrow or closed-angle glaucoma is something called a laser peripheral iridotomy, or LPI, and that's what you see in the pictures here. So in this case, a small hole is being made in the colored part of the eye, or the iris, and this acts as a backup drain. So that way, if your existing drain gets clogged, you have a tiny little hole, a tiny little drain there that can help drain the fluid, and you avoid going into what's called an acute angle closure glaucoma attack. This hole is microscopic. You can't see it. We can see it when we look at the slit lamp when you're in clinic, when we're examining you. The laser also just takes a few minutes to perform. However, this one, it is possible that you may notice a little pinch during the procedure, but you should not have any significant pain after the laser. You will be prescribed often a steroid drop afterwards that you can take anywhere from 1 to 2 weeks, depending on what your surgeon tells you. If you do have any discomfort, irritation, anything like that, that drop does a good job of treating that. It is possible for that hole to scar over a little bit in the post-laser period. It's not common, but it can happen. If it does happen, it's very easy to touch that up in clinic after at your post-laser visit, and then we just have you continue that steroid drop for a little bit longer. Again, no physical restrictions because there are no incisions. This is a laser. Some patients can experience a little bit of glare, light sensitivity, like some kind of visual phenomena like that after the laser. Not super common, but can happen. It's typically self-limited, so that will fade over time. So I'm going to shift gears a little bit to talk about surgical management. So there are two broad categories as well for surgery management. So there's one set of surgery options that involves us enhancing the existing drainage system. So we've talked a lot about the drainage system and the trabecular meshwork and all that. So these surgeries are designed to enhance your existing drain and to help it work better. Then the other set of surgeries are just abandoning that drain and creating a new drain. I will separately talk about another set of procedures that we often do in the operating room that are designed to decrease the production of fluid, decrease the aqueous production. We'll talk about that at the end. So first, I'm going to talk to you about enhancing the existing drainage system. And that category of surgeries are what we typically refer to as MIGS, or minimally invasive glaucoma surgeries. These have gained a lot of popularity, especially in the recent years, and can be highly effective and quite low risk. So these surgeries, like I mentioned, are designed to make it easier for the fluid in the eye to exit the eye out of the natural drainage pathway. And so you can, for example, put a stent in the drain. You can cut into the natural drain to make it larger, or you could even enlarge and flush the drain using a microcatheter. That's almost like putting Drano through a sink and getting anything that's clogging it or any strictures out of the drain. When we do these surgeries, we don't actually have to open up the outside layers of the eye like we do with some of the other surgeries I'll talk about next. They are performed directly inside of the eye through a tiny incision, often the same incisions that if you're getting cataract surgery at the same time, are often doing it through those same incisions, and they're anywhere from 1 to 2.5 millimeters in size, so very, very tiny. A lot of these procedures were originally intended to be done at the time of cataract surgery, although now most of them can be done standalone, meaning without cataract surgery at a separate time. But the thought process was, while we're doing cataract surgery, why not do something that can help with the glaucoma and help lower the pressure and especially help get you off of some drops. The recovery process, the postoperative drops, the postoperative visits are all very similar to if you just had cataract surgery alone. There are other procedures other than what's listed on this figure, but we're just going to focus on a couple while we're here. So with MIGS procedures, or angle surgery as we also call it, the natural drain is getting enlarged or flushed or cut, or a stent is being put into it. So I have some descriptive pictures here. If you see on the top towards the left, that's an example of something called canaloplasty. And so that is where I was talking about, where we flush the drain and enlarge it and help filter out fluid through that. And the bottom on the left, those are examples of different stents. So the bottom left is an example of something called an eye stent, tiny little stents that we put into the drain to basically prop it open. And in the middle is something called the hydrus, and that is also a stent, just larger, spans a larger amount of the drainage system to help also drain fluid. On the right, you will see devices that create what we call a goniotomy, and that's where we're actually incising the drain to make it larger, and there's multiple different devices on the market that can do that. So during and after surgery, no matter which angle surgery or MIGS surgery you're getting, it usually takes anywhere from 5 to 15 minutes, and if it's combined with cataract surgery, that amount of time is in addition to the cataract surgery time. Your eye is numbed with drops or a gel. In some cases, the surgeon may want to numb your entire eyeball by putting numbing medication into your socket. The anesthesiologist will be there to give you some relaxing medication through your veins. So you're not asleep. Most commonly, you're not asleep. You are awake, but often people drift off and they most commonly don't really know what's going on, and I don't remember all the details once we're done. Your eye is cleaned with a cleaning solution to sterilize the part that, the eye that we want to treat. And then we cover your whole eye, the rest of your face, and in some cases, part of your body, with a drape so that everything is covered except for the area that we need to operate on. We put a little clip into the eye, and that holds the eye open so that way you don't have to stress about trying not to blink and like staring, we would like you to stare straight ahead and not move around, but you don't have to worry about not blinking. You will see bright lights for sure. If it's combined with cataract surgery, you may notice a lot of color changes. A lot of people talk about that. You should not see instruments coming towards you, and you should not feel pain. If you do feel pain, please tell us. A lot of patients are nervous that if they say something, they're going to mess something up. Let us know. We want this to be a good experience for you. Of course, we want this to be safe and effective, but we also really care about this being a good experience for you. So please tell us if you're uncomfortable or extremely anxious or something, and we can help. We will turn your head, so you'll notice that. For angle surgery, we do turn the head to perform the procedure, so you'll notice that we turn the head and then turn it back to where you're like straight, lying back on your back again. After surgery, your eye will be covered, typically with a clear shield, and you will need somebody to drive you home. So if you get anesthesia, they won't let us even do the surgery if we don't know that you have a ride confirmed for you to go home, so you cannot drive. And you may be asked to take drops that evening. The surgeon may tell you not to use drops that day and may just tell you to start them the next day. That's just dependent on what your doctor tells you. In terms of after surgery, you will be prescribed an antibiotic and a steroid. The steroid is typically a little bit more frequent initially, and it basically decreases over time, usually around the course of the first 4 weeks. These are typically the same drops that you have to use during cataract surgery, which is nice, so there's not a big difference with that. And there's no real additional risk of infection because we're still working through that same tiny wound that we used for the cataract surgery. Again, this is if it's in combination. Your surgeon will tell you if you should continue your glaucoma drops or discontinue. I personally discontinue glaucoma drops after I perform an angle surgery because I like to see how well it works and then add back just as needed. But it's surgeon dependent. There's not necessarily a right or a wrong, and they will discuss with you dependent on your stage of disease and what your eye looks like. We typically see you 1 day, 1 week, and 1 month post-operatively, very similar to just cataract surgery post-operative visits. You may need to be seen more. It depends on how your eye is healing, depends on what your pressure is doing, and so those are usually the minimum visits. After surgery, you will typically have to sleep in a shield for the first week, and it's very important for you to not bend, lift, or strain at least for 1 week. It's very common for the eye to have some level of bleeding after surgery. This is actually a good thing. It means that the surgery was performed in the correct spot and that it's working. It can be disconcerting for the patient because it makes you blurry. That's normal. The eye does a very good job of absorbing that. In rare situations, if there is a lot of bleeding in the eye and the eye hasn't absorbed it, we have to go back to remove it. That's not common. The eye does a really good job of taking care of that. And because of that, sometimes the restrictions, the no bending, lifting, straining, can be a little bit longer than a week. Your surgeon will tell you if anything like that needs to change. Depending on your job, if you have a job where you have to do a lot of physical labor, we may need to ask you to not go to work for a little bit, and we can write you a note as needed. Very common for the eye to feel a little funny after surgery. You shouldn't have frank pain. If you do, please tell us, but you might feel like there's grit in the eye, or some people say it feels like there's an eyelash in the eye, and that's very common. That gets better. Artificial tears can help. Your eye may water a little bit, all normal and part of the healing process. The other thing I want to mention is, remember that if you're getting a cataract surgery plus an angle surgery, it's a different healing process from like your friend or neighbor or family member who is getting cataract surgery alone. I have a lot of patients that will get both, and they're kind of discouraged because when someone gets straight cataract surgery, they're seeing better sometimes that day, next day. It's a rapid recovery. When we're doing a 2-in-1, it's just a different process. Your eye has to heal from 2 surgeries instead of 1, and sometimes it can take a little bit longer. Instead of a day, maybe it'll take 4 or 5 days or a week, and that's okay. It's hard. I know it's easy for us to say that's okay. You guys are the ones going through it, but it's overall for the greater good. We know that intervening with angle surgeries is often better for the eye, better for the glaucoma compared to just using drops. And you will get there. You will get better. So it's really hard not to compare yourselves to someone that, like your friend who's had cataract surgery, but it's not the same. So try hard not to. Now I'm going to talk about a different set of surgeries, ones where we're abandoning the existing drain, we're creating a new drain. So in these cases, like I mentioned, we're abandoning the existing drain, we're building a new one, and there's different options in this category. I'm going to focus and talk briefly on something called a trabeculectomy, a tube shunt, and something called a Zen. So with the trabeculectomy, we are essentially making a trap door in the wall of the eye, and the fluid is draining from inside to the outside through that trap door, and that trap door is essentially modulating how much fluid is coming out of the eye, and it helps determine how low or high the pressure will be. A tube shunt is where it kind of looks like a computer mouse, actually. So if you think of the tubing of the mouse, that's the part that goes into the eye, and the part that you put your hand over, that's what we call the plate, and that sits all the way in the back of the eye, and there's a sort of like a scar tissue formation over it that's called the capsule, and that also helps to modulate the flow of fluid and helps to determine the final eye pressure of the eye after surgery. A Zen is something kind of in between the two. So there is a tiny little tube that's being placed in the eye, but there's no plate. So it's just a tube, and then it drains the fluid from inside to the outside into the area underneath the top layer of the eye. There are different ways to place the Zen. Traditionally, it was first introduced as being placed what we call ab interno, meaning from inside of the eye to the outside, and that's considered a minimally invasive way to place it. But nowadays, a lot of surgeons are placing it outside to in, where we have to actually remove the top layer of the eye and put it in that way. And there's no real right or wrong. It's surgeon preference, and whatever that surgeon feels works best in their hands is what's important. In any of these cases, the fluid that is draining from inside of the out is still underneath the top layer of the eye, and it's going to be absorbed by the tissues of the eye. So you're not going to notice, any weeping or drainage related to this fluid drainage. You might notice some increase in tearing initially. You will have stitches in the eye in most of these cases, and so this is different from the angle surgeries that we were talking about. And so sometimes those can cause a little bit of discomfort and irritation, which leads to tearing, but this is not the tearing of the fluid in the eye. So all of that is absorbed by the eye, and you're not going to notice an increase in drainage from that. So I'm going to first talk a little bit about the trabeculectomy. So we talked about the trap door. So we're making a flap. We call it a flap, which is the trap door. And that trap door has some stitches that are holding the trap door in place. Depending on how tightly or loosely those stitches are tied down, that determines how much fluid is going from inside of the eye to the outside. In the clinic, this is kind of a nice surgery, actually, because we can modulate your pressure and the flow in the clinic. And so sometimes we have to either remove the sutures, or sometimes we use a laser to cut the sutures that are holding that trapdoor in place. Once they're cut, that loosens part of the trapdoor, and it helps more fluid to flow out, and it lowers your pressure. So these are things that we can do in the clinic to help in the postoperative period. Sometimes the body heals a little bit too much, and it can cause scar tissue to form in that area and scar it over, and it can cause a surgery to fail. We do give you anti-scarring medication during the surgery to help prevent that, and sometimes have to add some extra in the postoperative period to help increase the anti-scarring properties. But even then, sometimes scar tissue can form, and we can do something we call a needling, which I know sounds kind of scary, but basically we're removing the scar tissue and reviving that surgery and making it work again. This can be done in the operating room. It can be done in the clinic. Your surgeon will talk to you about pros and cons of both, and you can make that decision together. The nice thing with this surgery, what's amazing is some people get the surgery and it works for years and years and years. Many of our surgeries have they don't last forever. Most of them, I mean, I guess I should say all of them, except for this one has the potential to last for a really long time, but most of them end up failing, even say in the 3 to 5 years. Sometimes they last longer, but we have many tools in our toolkit, which hopefully you can see throughout these talks, where we can always think of something else. Once one thing fails, we can move on to the next thing. This is a surgery actually that can last for a really long time. I have some patients that have gotten a trabeculectomy literally like 20, 25 years ago. It's still going strong. It all ultimately depends on how your body heals from the surgery and how it heals that area where that trapdoor is. So the surgery is done in the operating room. It can take anywhere from 30 to 60 minutes, just depending on your eye. Your eye is numb, again, with drops, gel, or a lot of times we will numb up the entire eyeball by putting medication in your eye socket. You will get relaxing medication again so that you are nice and relaxed throughout the surgery. Your eye is cleaned with a cleaning solution. We place a drape over your face again, so only the eye that we're going to operate on is exposed. And we place a little clip in the eye again to hold your lids back so you don't have to worry about not blinking. We put some anti-scarring medication in the area that we're going to be treating. And then we open up the top layer of the eye, which is called the conjunctiva, and then we make the tiny little trapdoor, or the flap. Underneath the flap, we actually make a tiny microscopic hole, and that's actually what allows the fluid to go from inside to the outside. That hole is the connection between the inside of the eye to the outside of the eye. Then we close the flap door on top of it, stitch that closed, and then place the conjunctiva on top of it and close everything. Like I mentioned, you will have some stitches, so it's very common to feel a little bit of discomfort earlier in the postoperative period. It doesn't typically last the entire time you're healing. Your surgeon can give you an ointment that can help you feel a little bit better and help soften the sutures a little bit quicker. But in general, they shouldn't cause significant discomfort. Very common, you will see bright lights during this as well, but you won't see anything coming towards you again. But you'll notice some bright lights. You shouldn't feel any pain. If you are uncomfortable, please let us know. We can help fix that. And afterwards, your eye will be covered by a patch or a shield, and you will need someone to drive you home. So after surgery, your eye typically will be covered. Most commonly, your surgeon will tell you not to remove that patch until the next day. We often remove it in clinic, or in theory, you could remove it yourself in the morning. You will be prescribed drops, again, a steroid drop and an antibiotic drop. Often that steroid drop is given very frequently in the initial postoperative period, sometimes even often every 1 to 2 hours, and then it's tapered down throughout the course of the first couple months. Your doctor will tell you if they want you to continue glaucoma drops or not, and again, I stop them right after surgery, but they'll talk to you about that. You are often seen a little more frequently after this surgery compared to what we've been talking about, so definitely 1 day, 1 week, 1 month, but often many visits in between that. It all just depends on how your eye is healing, but it is typically more frequently than that. You will have to wear a shield to cover the eye to sleep, usually for the first week or two. And it's very, very important in this case to avoid bending, lifting, straining. I know we talk about it after all surgeries, but after these bigger surgeries, really important to try your hardest not to bend. And it's hard, you don't even realize when you're bending because it's such a part of our daily routine. Even tying your shoes or unloading or loading the dishwasher or your washing machine, depending on if it's front-loaded or top-loaded. And so all of that those are all things that you have to kind of think about and you're not used to thinking about, but it's really important to avoid that. Very common to feel like your eye has something in it. Again, you have those stitches. That shouldn't last for very long. You shouldn't have really bad pain. If you do, please tell us. It is possible for your eye pressure actually to be too low after the surgery. It typically doesn't last forever that way, but especially when your pressure is too low, it's really, really important for you to be very mindful about not bending, not lifting, just take it easy. So now I'm going to switch gears a little bit and talk about something called an aqueous shunt or a tube shunt. So this is what we were talking about that looks like a computer mouse. It is similar to a trabeculectomy in that it allows the fluid to flow from inside of the eye to the outside. In this case, it's flowing through a tiny little tube. It then goes from the inside of the eye to the outside through that tube. It ends up in that plate that I was talking about that sits all the way in the back of the eye and into this kind of bubble of fluid that is basically like what we call, it's covered by something called a capsule, and that's a layer of scar tissue that helps to modulate the flow of fluid. That fluid that's collecting underneath this capsule, like I mentioned, is absorbed by the eye, so you're not going to tear. Once you fully recover from surgery, you can't feel it, you can't actually see it. However, if you were to lift your lid and look down, it's very common for people to notice like a little bubble where that capsule and that plate is. And some people can see a little white square where we put kind of like a little covering over the tube so that it stays protected underneath the surface of the eye, and that's all normal. But otherwise, if you're looking at someone head on, no, you typically cannot see the tube. There are different types of tube shunts, something that's called valved and non-valved, and the type of tube shunt you get depends on your glaucoma, and you and your surgeon will discuss which one makes sense for you and your disease. The process of getting the tube is very similar to the trabeculectomy, as in it's done in the operating room, you're sedated, the eye is numb, you go home with the eye covered, you will need a driver, and you come back to see the doctor on post-op day 1, and then you start your drops. The recovery process is also very similar to a trabeculectomy in terms of your ability to go back to work. Depending on your job, you may need to take it easy for a little bit, which we can write you a letter for. You will have the same restrictions, no bending, no lifting. Similar to the trabeculectomy, your pressure can be a little bit too low. So again, very, very important to be very mindful of not doing any bending or lifting during that time period, and until your surgeon tells you, okay, now you can kind of ease back into normal life. I'm going to talk really quickly about the Zen Gel Stent. So this is also a tiny little tube, but again, does not have that plate that we were talking about. It's very small. It's like the length of an eyelash, very, very tiny, and it connects the inside of the eye to the outside to the space underneath the conjunctiva. And this is the same space that the fluid goes into from a trabeculectomy or a tube shunt. So a similar process in that way. Like I mentioned, the Zen originally was designed to be placed from inside of the eye to the outside of the eye, which kind of made it a little bit less invasive than some of these other things that we have talked about in the last few minutes. Although nowadays, many of us do it from the outside to the inside and have to open up the conjunctiva. In this case, you will need anti-scarring medication again, just like with the trabeculectomy, and we can enhance that in the postoperative period by giving you more. This is also a situation where the surgical site can scar over, and if it does, we can do that needling again to remove that scar tissue and try to revive the surgery. This is more often done in clinic, but can be done in the operating room, just depending on what you and your surgeon decide. The recovery process actually is a little bit more straightforward, a little more comfortable compared to the trabeculectomy or the tube shunt. The surgery itself is shorter. Like I mentioned, you are more comfortable, your vision recovers a little bit quicker, and the complications in theory can be a little less severe. And so depending on the stage of your disease and how your eye looks and a variety of factors, you and your surgeon can decide which option is best for you. So overview, we talked about options where we enhance the existing drainage system, and then we talked about options where we abandon the existing drain and we make a brand new drain. Now I'm going to talk about some options that actually turn down the production of fluid. And so in this case, it's almost like turning the faucet down, like turning the sink down. So you still have fluid, you still want fluid to be made, the eye still needs some pressure, you just want less. And so Dr. Butler touched on this a little bit, but the aqueous fluid that we talked about, the fluid that the eye makes, is made by a gland in the eye that's called the ciliary body. And so these procedures to decrease the production of fluid are all geared around treating the ciliary body and having it function a little bit less so that it's still making fluid but not quite as much. There is a micro-invasive or minimally invasive way to do this where we do it from inside of the eye, and that's what's circled here. There's also a separate one that's not on this graph that is completely non-invasive, non-incisional, that we will talk about shortly. So endoscopic cyclophocoagulation, or ECP, is a procedure where we use a tiny little probe. It goes inside of your eye. The probe has a camera on it, so we can actually see the little finger-like processes of the ciliary body. We call it the ciliary processes, and that camera projects on a screen, and so we can actually see in real time that as we are treating the ciliary body and in theory decreasing the fluid production. This laser is relatively gentle. It can be done on eyes that have decent vision because the risks are less and the complications are less severe. There is a theoretical risk of infection because we're entering the eye, but it's still small. It's similar to the risk of cataract surgery. There is also a risk of having a slightly increased amount of inflammation. In general, the process of having it and the recovery and appointments and all that are very similar to when we talked about cataract surgery plus minus angle surgery. It's a very similar process. You will get steroid drops and antibiotic drops, again, very similar to cataract surgery. You can do it at the same time as cataract surgery as a MIGS option along with cataract surgery, or you could do it standalone without cataract surgery if your surgeon just thinks you need better pressure control. There is no real increased risk in bleeding. It is theoretically possible to have pressure that's too low, but it's very uncommon with this procedure. Now I'm going to switch gears to talk about the traditional Transcurral Cyclophocoagulation diode. So this is what I was talking about, the non-invasive, no incision way to apply laser energy to the ciliary body. This can be done in the clinic. I have done it in the clinic, but often we do it in the operating room because it can be a little uncomfortable. So we take you there, we numb up your entire eyeball by putting some medication into your eye socket, and then the anesthesiologist is there so that you can drift off a little bit and you don't really know what's going on when we're doing it. The procedure itself is fairly quick. It's under 5 minutes. Like I mentioned, there's no incision, so there's no real infection risk, and we don't expect any bleeding. You can have some inflammation in the front of the eye and in the back of the eye with this procedure. Because of that, particularly inflammation in the back of the eye, that can cause some fluid to build up in your retina, and that can make your vision a little blurrier. So traditionally, we would do this procedure on people who had worse vision. However, we have changed the way we applied this laser. We've changed our settings to gentler settings, and now we have found that we could do it on eyes with better vision, and they do well. I've done it many times on eyes with pretty good vision, and people have very good results. There is another version that's even gentler, and it's called micropulse CPC, that has even less risks. However, the long-term success and the response rate is just not quite as predictable, and it can depend on the individual. So some surgeons offer that and some don't. You shouldn't feel any pain during the procedure. Your eye may be a little bit sore afterwards. That's not uncommon. Your eye will be numb by that medication that goes into your eye socket for up to 6 to 8 hours. So you will keep that patch on. We will put a patch on after the laser, and you'll keep it on for several hours. And some will ask you to remove the patch and start your drops after that. Some will ask you to wait till the next day. Your next visit could be on day 1 or week 1. For example, I like to do week 1. And so you will take your patch off yourself, you'll start your drops, and then I'll see you at post-laser week 1. You'll be on a steroid drop. You usually will not need an antibiotic because there's no incision. And whether or not you continue glaucoma drops will depend on what the goals of this procedure were, and your surgeon will tell you that. There are no restrictions after this because there's no incision, so you can go back to regular life right afterwards. So I want to talk to you next about, my slides are not advancing again, about what's next on the pipeline. This is just a couple quick slides. So we're really lucky that we have a lot of companies out there that really care about advancing the surgical options for our glaucoma patients, whether it's to decrease their pressure and or decrease their medication load. So there are many, many things out there in the pipeline that are really exciting, and I'm basically going to talk to you about just a couple. So the first thing I'm going to talk about is by Acuvue Health. It's called the Zelix microcoil. It is considered a MIGS, a minimally invasive glaucoma surgery, and this is basically a stent. It's a large stent that encompasses nearly 180 degrees of the eye, of the drainage system, and it kind of looks like a stretched out slinky. It's like a long coil, and it's tiny, so minimal mass and very open architecture from those large coils, which help to maximize the drainage of fluid through the drainage system. It's a pretty straightforward placement in the eye. Currently, it's undergoing trials outside of the United States, so it's not going to be ready here for some time, but is a promising new stent device that we can use. Another example by VC Technologies is called the Visiplate Aqueous Shunt. So this is similar to a tube in that there's part of the body goes inside of the eye and part of it goes outside, but it's not a tube shunt because there's no actual tube. It does go underneath the conjunctiva, so the top layers of the eye. Part of the body goes into the eye, like I mentioned, part of it is outside, and the part that's in the eye has multiple tiny little microchannels that help the fluid to go from inside of the eye to the outside of the eye. It's made from a porous, non-fibrotic material, so in theory is less likely to develop scar tissue over it that can cause it to fail. It's very thin, so it's aesthetically, in theory, more pleasing and more comfortable. It is pretty straightforward to place, only a couple surgical steps, and the company is in the process of launching a large clinical trial in the United States, so hopefully we'll have it in our hands fairly soon. And finally, I want to talk to you about something that's being developed by Serene Ophthalmic, which is a hydrogel spacer. So they're developing a device that's basically can inject a tiny amount of gel into the deep wall of the eye where there's actually a secondary drainage pathway, which I have not focused on. We focused on the traditional primary drainage pathway of aqueous fluid. There is a non-traditional secondary drainage pathway that this device focuses on. And so with this tiny needle, you aim into the area that secondary drainage pathway exists, and you basically inject a tiny amount of gel that goes in there and enlarges it. The nice thing is this can be performed in clinic. You just numb up the eye and give this and can do it in clinic, which is easier, admittedly, compared to going to the OR, which all of our other procedures have talked about. There are no additional medications or drugs needed. Everything is in that vial. Currently, it's in the preclinical phase, meaning has not been tested in humans yet. They have had very good and very safe results in rabbits and monkeys, and it can be repeated. So it's just exciting. I realize that's not in humans, but it's exciting potential for what we can do for patients in the future. So in conclusion, as we've discussed, there are lots and lots of laser and surgical options out there, and even more that are being constantly developed. Some of them are less invasive and have an easier recovery. Others are more invasive and have a more involved recovery process. At the end of the day, you and your doctor will work together to decide which treatment plan makes the most sense for your specific situation. Thank you for your attention, and I hope you guys learned something from this. Thank you so much.